You are about to start your clinical rotation in women's health, and if you are anything like me, you are going to love it. There are so many facets to obstetrics and gynecology, and there's honestly never a dull moment. Whether or not you are eager to start this rotation, I encourage you to keep an open mind as you may encounter women's health issues in other areas of healthcare, such as primary care and the emergency department. Having knowledge in a range of specialties helps you to become a more well-rounded nurse practitioner. With that being said, let's get started. In this lesson, we are going to touch on the most current pap smear guidelines as provided by the ASCCP and ACOG. It is imperative that a proper gynecological and family history is taken in order to coordinate the proper patient plan. A pap smear is performed to screen for cervical cancer. Cervical cancer is caused by the human papillomavirus. HPV is a virus that can cause genital warts and cervical cancer. There are at least 100 different strains of HPV, with 14 high-risk strains and type 16 and 18 being linked to cancer. It is most commonly transmitted through sexual intercourse, but can be transmitted through skin contact. It's important to note that there are no symptoms. Regardless of age at onset of sexual activity, initial pap smear screening begins at 21 years of age. From age 21 to 29, pap smear screening can be performed every 3 years, assuming results are negative for dysplasia or normal. From age 30 to 65, a pap smear with HPV co-testing can be done every 5 years. A pap smear alone can be done every 3 years, or HPV test alone every 5 years. Over the age of 65, the patient may consider discontinuing pap smear surveillance if she meets certain criteria. Now that we know what the screening guidelines are, you may be wondering what happens if you get an abnormal result on a pap smear. There are varying levels of dysplasia, and management of an abnormal pap smear includes consideration of the patient's medical history. In general, an abnormal pap smear warrants a colposcopy exam, which is a special microscope used to closely examine the cervix. Endocervical and cervical biopsies can be done at this time for more diagnostic testing. Management of colposcopy results depends on the severity of the dysplasia and range from conservative management with pap smear surveillance to surgical management via LEEP, cone biopsy, or excision. I highly encourage you to download the ASCCP app as it allows you to input specific screening results with recommendations for management. It's important to ensure that your patient has had other proper preventative screening exams offered and completed. Per the American Cancer Society and ACOG, women should be screened for breast cancer annually beginning at the age of 40 and indefinitely if the life expectancy is greater than 10 years. Breast ultrasound can also be another useful tool in screening for breast cancer in women with fibrocystic breast. As with most guidelines, a personal or family history of the related cancer warrants earlier screening and genetic counseling. Per ACOG, screening for osteoporosis using a DEXA scan to determine bone mineral density should begin at age 65. This should be repeated every 2 years depending on risk factors. Risk factors that may warrant screening earlier than 65 include the use of certain medications, certain autoimmune and GI diseases, calcium and vitamin D deficiency, excessive vitamin A, increased caffeine and sodium intake, use of antacids, use of alcohol, smoking, a sedentary lifestyle, thin stature, and a recent fall injury. Per the American Cancer Society, colorectal cancer screening may begin after the age of 45 via stool test, flexible sigmoidoscopy, colonoscopy, and/or CT colonography. In practice, I will review the guidelines with the patient and provide the appropriate referral to GI to have the screening performed. While you may be wondering why even bother with colon cancer screening in a gynecology office, it's interesting to note that many women treat their gynecologist as their primary care provider. Additionally, colon cancer can be linked to endometrial cancer via the Lynch syndrome. Providing the appropriate resources and taking the time to elicit the appropriate history can really make the difference in preventing patient illness and disease. In this lesson, we are going to touch on some of the most common issues encountered in gynecology. Vaginitis is the medical term used to describe an inflammation in the vagina that causes discharge and itching. The two most common causes of non-STI related vaginitis that I see in clinical practice are Candida and bacterial vaginosis. Candidal vaginitis, commonly known as a yeast infection, is extremely common yet very frustrating for the patient experiencing symptoms. It is commonly caused by C. albicans, and symptoms include thick discharge, itching, and irritation. It is important to note that women who present with recurrent Candida or infections every 3 months should be screened for immunocompromised states or underlying disease processes such as diabetes and HIV. The good news is that treatment of candidal vaginitis is fairly straightforward. Over-the-counter options are available in the form of intravaginal meconazole, such as Monistat. Prescriptive options include circonazole vaginal cream or fluconazole oral tablet. The remainder of the plan of care involves extensive education regarding proper female hygiene, using cotton underwear, and changing sanitary pads regularly. Additionally, changing clothes after swimming or exercising can also be really helpful. Probiotics that contain lactobacillus are extremely beneficial in preventing recurrent candidal vaginitis and should be initiated even after just one episode. The other type of vaginitis commonly seen in practice is bacterial vaginosis. The classic symptoms of this type of vaginitis usually involve a vaginal discharge with foul odor. Patients are often very self-aware of this odor and mistakenly assume that it has to do with their own personal hygiene, which is not the case. An anaerobic gram-variable rod is responsible for bacterial vaginosis, and it is most often triggered by a change in vaginal pH, usually following sexual intercourse or a menstrual cycle. There are multiple prescriptive options currently on the market for bacterial vaginosis, including oral and intravaginal metronidazole, tinidazole, Nuvesa, and Solosec. Once again, education is key and should include counseling the patient to use condoms regularly, avoid douching, and use of a daily probiotic with lactobacillus to balance the vaginal flora. Sexually transmitted infections, or STIs, can have serious consequences if left untreated, which is why screening and prompt treatment are a critical part of the role of the gynecologic nurse practitioner. In general, STI screening involves testing for chlamydia, gonorrhea, HIV, syphilis, hepatitis, and trichomonas. In this lesson, we are going to cover chlamydia and gonorrhea specifically. The most current CDC data reported 2.5 million cases of chlamydia and gonorrhea combined in the United States alone in 2021. Women who are sexually active under the age of 25 should be screened for chlamydia and gonorrhea annually. Women aged 25 years and older with risk factors should also be tested annually. The important aspect of the symptomatology of chlamydia is that there actually may be none. Other patients may complain of dysuria, vaginal discharge, rectal pain, or bleeding. Treatment of chlamydia involves treating the patient and the partner. In some states, providers are legally allowed to provide expedited partner therapy, or EPT, which involves prescribing treatment to the partner without physically evaluating the partner. This is especially useful for those patients with poor access to healthcare or who are unlikely to take the diagnosis seriously and delay treatment. Lack of treatment or delay in treatment in women can cause scarring of the fallopian tubes, leading to PID and infertility. Per the CDC, first-line therapy in the non-pregnant patient is doxycycline 100 mg PO BID for 7 days. Alternate therapy involves the use of azithromycin 1 gram PO for 1 day. Gonorrhea may also present without active symptoms in some patients. Those with symptoms typically complain of dysuria, vaginal discharge, dyspareunia, fever, and sometimes pelvic pain. As with chlamydia, treatment of gonorrhea involves treating the patient and the partner. Lack of treatment or delay in treatment in women can cause scarring of the fallopian tubes, leading to PID and infertility. Gonorrhea should be treated with ceftriaxone 500 mg intramuscular in a single dose. If chlamydial infection has not been excluded, then you should go ahead and treat the patient for chlamydia as well with the medication regimen described previously. Education is key in treating and preventing STIs. The patient and her partner should complete the full course of treatment to prevent reinfection once sex has resumed. Additionally, consistent use of condoms can prevent STIs in general. A repeat culture, or a test of cure, is recommended 4 weeks after treatment to document resolution in the STI. Complete STI screening should be offered to any woman that is treated for an STI. It can be difficult to give a patient STI results. I always recommend that you give them the mental space to process the results before going into explaining the treatment plan. Additionally, allow them to ask questions and voice their concerns. In this lesson, we are going to be discussing the basics of obstetrics. It is no surprise that it is my favorite specialty, given that I've been working in obstetrics and gynecology for the past 15 years. I find that many of my students enter this clinical rotation feeling very overwhelmed and really nervous. As with anything, the only way to overcome a fear is to learn more about it, so let's get started. A full-term pregnancy is actually a full 40 weeks. In general, routine obstetric visits to the healthcare provider take place about every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and then weekly until delivery. Obviously, this may change if a pregnancy is considered high risk. Understanding basic obstetric concepts means going back to the anatomy of a pregnant woman. Refresh your knowledge with the basic anatomy of the fetus, placenta, amniotic sac, uterus, and cervix. A significant part of caring for the obstetric patient, especially when labor symptoms are present, is that of the pelvic exam, also known as the VE or vaginal exam. A VE is reported by determining dilation, effacement, and station. Speaking of labor, there are also different stages a woman goes through when she's having a baby. The first stage includes early labor, active labor, and transition. Essentially the labor process up until about 10 centimeters dilated. The second stage of labor is the pushing stage, and just like it sounds, this is the stage in which the mother actively pushes. Things to consider in this stage are the risk of an episiotomy or laceration, a vacuum-assisted delivery, and a possible cesarean section. The third and final stage of labor is delivery of the placenta. Considerations during this stage include retained products, usually placental tissue, that may lead to persistent hemorrhage and unresponsiveness to medications. In this case, manual removal of the products is necessary. Unless you are a certified midwife, you may not see yourself delivering babies on the hospital unit as a nurse practitioner. This does not negate the fact that you should still be knowledgeable in the childbirth process and potential complications. Not only that, but you can also help to educate and prepare the patient for childbirth. The postpartum stage has commonly been referred to as the fourth trimester, and for good reason. Many women struggle to find their footing and adjust to this new stage of life due to a lack of preparation. This is where education comes in. By counseling expectant mothers on what to anticipate in the immediate and extended postpartum period, we can lay the foundation for a successful transition into motherhood. The following are red flags that require further evaluation and intervention. Passage of blood clots larger than lemons, saturating a peripad in 1 hour or less, a fever of 100.4 degrees Fahrenheit or higher, problems with urination, foul vaginal discharge, increased pain at the site of the incision or episiotomy, signs of a DVT, and signs of mastitis. Screening for baby blues and postpartum depression is one of the top priorities at the initial visit following delivery. Many hospitals also screen their patients prior to discharge home. The Edinburgh Postpartum Depression Scale is the standard of care and should be done at every initial postpartum visit. There are two common types of mental health changes that can occur postpartum: baby blues and postpartum depression. Approximately 25 to 50% of mothers experience baby blues. The symptoms of baby blues include the inability to sleep, excessive crying over small things, feeling inadequate, and irritability. Baby blues may start several days after delivery and they eventually fade after several weeks postpartum. Postpartum depression affects 10 to 15% of mothers. The symptoms include all of the symptoms of baby blues, plus the inability to concentrate, feeling guilty, inability to cope with anxiety, a lack of interest in the baby and self-care, hyper concern regarding the baby, headaches or chest pain unrelated to medical conditions, and or thoughts of harming themselves or the baby. These symptoms may begin 6 to 12 weeks postpartum and can actually last up until 3 years following birth. Treatment for postpartum depression includes providing resources for support groups and therapy with professional mental health specialists. Encourage the patient to utilize their partner, family, and friends as part of their support system. Remind the patient to prioritize themselves with simple tasks like eating, showering daily, and getting outside to go for a walk. The patient should be encouraged to celebrate each achievement, no matter how small, and understand that postpartum depression is treatable and not a reflection of them as a mother. Additionally, medication compatible with breastfeeding can be initiated to treat postpartum depression in conjunction with the previously mentioned treatment plan. It's important to note that the care of the obstetric patient does not end with childbirth. In fact, the system is lacking in its support of women during this time. I encourage you to be the change and implement the appropriate care to all women in the postpartum period. Question 1. A 22-year-old G0P0 presents for a routine annual exam. She expresses anxiety as this is her first gynecological exam. She is sexually active with her male partner using combination oral contraceptive pills for 4 years now. She denies using condoms. Her menstrual cycles are regular every month, and she denies any other complaints today. Her vital signs are as follows: heart rate 100, respiratory rate 18, BP 138/88, BMI 23. What is your priority for today's visit? Yes, the correct answer is B. Initial pap smear screening begins at age 21, and screening for chlamydia and gonorrhea is recommended in women under the age of 25. Question 2. A 33-year-old female presents to your office with complaints of white vaginal discharge with itching for 3 days. She recently returned from a vacation in the Bahamas with her spouse and is concerned that she may have caught something in the water. She states that she has never experienced anything like this. Her menstrual cycles are irregular and she denies pelvic pain. Her vital signs are as follows: heart rate 80, respiratory rate 16, BP 116/72, and BMI 31. Her last menstrual period was 3 weeks ago, and her urine pregnancy test is negative today. What is your anticipated plan of care? Yes, option A is the most appropriate choice, as the patient is most likely experiencing candidal vaginitis. The remainder of the options are not appropriate. Question 3. A 26-year-old G21001 at 29 weeks gestation presents for her routine OB visit with you today. She seems to be doing well and reports adequate fetal movement without leaking of fluid or vaginal bleeding. She does note a nagging headache for 2 days and seeing occasional floaters. Her vital signs are as follows: heart rate 95, respiratory rate 16, blood pressure 150/95, urine dipstick reveals +2 proteinuria. She has had a 7-pound weight gain since her last visit, and you note bilateral lower extremity edema today. Your treatment plan includes the following orders. The correct answer is C. You should also include an order for uric acid, as elevated levels are seen in preeclampsia secondary to altered kidney function. That's it, guys. I'm so happy you were able to join me today, and I hope you were able to really process this critical information. Remember, we have all been where you are at some point in time. Don't lose sight of your goals, and you will succeed. Don't forget to check out NPHub.com to get access to all of our specialty notebooks. Reviewing these notebooks before and during your rotation will help you lay the foundation for a rewarding learning experience and maybe even a potential job offer down the road. Good luck.